Good afternoon and welcome back to this teleconferencing session of PGDHHM program. Before the break, Dr. Das has very comprehensively and very elaborately told you about the medical record departments, what is medical record department, how it is organized, what are the functions, and how the records has to be maintained. Now, continuing with the course 5, now we'll go on to one or two more important areas which we can cover within 45 minutes. And to begin with, what we'll do that we'll start with the hospital acquired infections. And I think you must have, if you have gone through your block of hospital acquired infection, you must have seen that what are hospital acquired infection, how they spread that, and what is the importance of knowing for a hospital administrator that how to prevent this hospital acquired infection. So that will be covering, and then subsequently I will request that if there are students sitting at other centers also, we will be just there is a request from the students sitting here that disaster management need to be covered. So what we will do that if there are certain queries regarding this, or if you have some questions, some supplementation you want regarding disaster management, we have got two experts with us, Colonel Rao and Dr. Das. They will be answering to your queries. So just without wasting any time, I will request Colonel Rao to tell you about the hospital acquired infections.
Okay, now we will discuss about hospital acquired infections. In that, first we will start from the definition itself. Expressed in simple terms, it can be defined as one that was neither present nor incubating at the time of admission to the hospital. Remember that the incubation period nowadays varies so much, from 6 weeks to 6 months to anything, not definable also in many cases. So that will also come under the hospital acquired infection. Especially the post-discharge analysis has to be carried out, that even after the patient is discharged, hospital acquired infection can be there in the hospitals. But otherwise, many definitions cover that it can be up to 72 hours, but it is not actually true, because the time limit you cannot specify. That many times it may, in the cases of hepatitis or HIV, and these periods cannot be specified. But commonly it is up to 72 hours. Any infection after 72 hours will be considered as HAI. Everybody should be aware that it has lot of disadvantages because of hospital acquired infection hospital faces. There is an increased morbidity and mortality in the society and in the hospitalized patients, increased length of stay, increased cost of treatment because you are pumping in so much of antibiotics. There are wastage of limited resources all over India. We have very less resources in terms of beds, in terms of doctors, in terms of medicines. The productivity goes down, psychological trauma is there to the patient, image of the hospital is at stake. You must have heard a lot of media news in this regard, that many cases of endophthalmitis or many other stories are there in the media. Legal implications, of course, it's the responsibility of the hospital to prevent hospital acquired infections and do maximum to prevent all this. There are newer organisms which have come in, like you have MRSA, VRE, which is methicillin resistant Staphylococcus aureus or vancomycin resistant enterococci, ESBL. All these are newer varieties which are coming up. The more antibiotics you use, more bugs will come. Increasing number and complexities of services, emergence and growth of special units like bone marrow transplant units you have, organ transplant, implants of the foreign body is there. Invasion is done every day through the endoscopes or various other devices, central lines and other things which are causing more infection. A greater number and variety of caregivers are there. Prevention of infection is becoming challenging. New diagnostic and therapeutic techniques are there. Patients are immunocompromised. Population is getting aged, and newer drug-resistant microorganisms, as I was telling you. Some of the estimates of CDC estimates are there in front of you in various countries also, and services-wise also. You can see ICU has the maximum number of infection rate in terms of So that becomes a critical area to look at. And there was a survey carried out by WHO in 1988 across all the continents, where it was found that approximately prevalence is 8.4%. In our country, it is estimated, there is no data as such available, but the estimates are there that the surgical site infection rate is quite high. Various committees have addressed this issue. Dr. K.N. Rao committee and Dr. Sharad Kumar committee has addressed this, and all of them have advised to have a central database and hospital acquired infection committees. So they also recommended that national HAI board should be there, but nothing has been constituted to that effect, and though no nationwide data is available. As I said, that we do not have any authentic data available, but individual hospital-wise data are available. The surgical site infection rate is around 25%, and various types of organisms are found. In the epidemiological point of view, we have agent, host, and environment. In that, agents are known to you: bacteria, viruses, fungus, parasites. Conventional pathogens like Staph aureus, Group A, Streptococci, Staph epidermidis, Salmonella, and many other have come in, which are becoming important: Clostridium difficile, as well as various other Acinetobacter has come up in a very big way from 1980 onwards. So pattern is also changing from Streptococci, Staphylococci, gram-negative bacilli. Now we have MRSA, VRE, and Acinetobacter. Agent factors dependent on virulence, opportunism, colonization, and invasion secondary to viral infection. High infecting dose is required. In the host factor, we have seen earlier that ages are increasing, extremes of age, decrease in resistance, various therapeutic practices like immunosuppressive drugs, presence of underlying disease. In environmental factors, we have, of course, staff, patients, equipment, housekeeping, linen, laundry, CSSD. In linen laundry also, like though it's a separate topic as such, there are various factors which needs to be considered. Then we have an internal air quality control aspect also. So basically, sources of infection are endogenous and exogenous. In endogenous, the patient's flora itself becomes a agent for hospital acquired infection, whereby if there is any invasion from outside, this flora will produce the infection. And this is a diagrammatically depicted pattern, endogenous as well as exogenous. In that, air, equipments, instruments, and fomites are important. Then this is just to show you the chain. That is, the various factors for transmission is also very, very important, other than the agent and host. And in that means of transmission, there are inbuilt mechanism to control this. For example, if you have a direct contact, then hand washing is sufficient. Indirect contact, the decontamination is the best way. And droplet infection, you can keep the distance between the beds. Droplet nuclei, you can have a good air conditioning mechanism. And common vehicles of transmission, that is blood. We have stringent rules. We have discussed blood banking also last time. Various high-risk areas in the hospital can be defined by the hospital itself, but generally known high-risk areas are ICUs, burn units, operation theaters, post-operative units, dialysis units, organ transplant units, isolation wards. Various types of important hospital-acquired infections are UTI, pneumonias, which is also called ventilatory associated pneumonias, or what we call VAP, surgical wounds or surgical site infection, it is called by CDC, that is very high in our country. And then bloodstream infections or device related, which are going into the blood also. So all that combined infections are also there. So it is a known fact now, it has been proved beyond doubt, that if you take preventive mechanism in terms of hospital acquired infection committee and strict surveillance and control mechanism, then you can bring hospital acquired infection rates by 32%. So it's a world proven fact. So you have to have a proper mechanism by which surveillance and infection control should be carried out. So the cornerstone, as you can see on viewfoil, HICC, or Hospital Acquired Infection Control Committee, has to be formed, and it is a policy making body, multi-stick in terms of multi-speciality, and on ground workers are from the infection control team. So hospital acquired infection control committee can be chaired by physician or microbiologist or the medical superintendent. Anybody can become chairperson. Member secretary preferably should be microbiologist if it is available. If it is not available, then a clinician can also take over. various members and co-opted members have to be from different specialty and supportive services. Hospital administration has to be member of this committee or maybe chairing the committee because the resources are involved heavily. You have to implement certain programs and control measures. So that is important. Infection control team consists of microbiologists and infection control nurses. These are actually the soldiers. Infection control nurses are the soldiers on ground who are working, collecting data day in and day out. The tasks of hospital acquired infection control committee, as I said, is a policy making, formulate simple, effective, practical policies, then review them, meet every month, update, keep a control over an infection control team, and advise the top person accordingly. Role of microbiologist, which is the infection control team in charge, he has to coordinate with various HICC members. He has to give you antibiotic sensitivity pattern, what we call antibiogram of the hospital, and how it varies in various areas, and what is their the feedback must reach the clinician so that they can take the appropriate measures. Surveillance. Now this infection control nurse has a very important aspect. Her typical day actually starts from the laboratory, and she collects all the data and then goes on ground, checks in each and every ward which are the patients who are on the various devices like catheters, and central line is going on or ventilators are there, and accordingly collects the data and discusses with the clinicians, discusses with the pathologist, and then compiles the data. That means she is actually keeping a track of all patients with intravascular catheters, urinary catheters, post-operative patients, and patients on the ventilators. This is some of the pro forma for recording infection rates by the nurse, total number of operation, post-operative wound infection, central line infection. So these are some of the examples of various infection control measures. Most important, people say hand washing, and hand washing. This is the most important preventive mechanism to control the hospital acquired infection. And hand washing surveillance has now become a criteria for quality control also. In all the criteria, national as well as international criteria, this is mentioned. Hand washing is of different types, social, then procedural as well as surgical hand washing. So different timings are recommended for this. The correct procedure of hand washing is in front of you. Then the standard precautions. Now earlier they used to be called universal precautions, but now they are called standard precautions. Or these are in front of you again: sharps, waist, linen, gown, mask, gloves. Washing your hands become very important. Some of the protocols which have to be designed by the infection control team as well as by the HICC are for the peripheral line, for changing of vascular catheters, for changing of administration sets, urinary catheter, what precautions to be taken, closed system has to be used. Care has to be taken during transportation of patient. For the ventilators and the tubings, how these disposable circuits have to be changed. HMEF care has to be taken. For the suction, 2 persons are required. You can't do it alone. All these become part of your protocols, which has to be a part of your hospital infection control manual. And these are again some of the examples of the measures. This is a typical blood spill which is being tackled by a safai worker or a sanitary worker. This is how the correct methodology. But in this example you can see there is something wrong which is going on. The person is taking blood, but he is not taking any precautions in terms of standard precautions. So these are examples actually which are being given by NACO also in their booklets. So here they are in front of you. This should be avoided totally. When the blood spills on the lab forms, we just keep the blood samples on the lab forms just to avoid marking it and avoid any other measures. So this type of laxity should not be acceptable, and we have to have certain guidelines properly developed. Like you have to have guideline for accidental post needle stick injury. Needle stick injury is a very important aspect from employee safety point of view, and those analysis has to be carried out. Guidelines for control of MRSA. Now MRSA has become a bugbear in the ICUs. Protocols for wound care, pre-op preparation for major surgeries, general principles of specimen collection, care of neutropenic patient, hospital antibiotic policy. Now this is again a very major area where we need to, everybody is able to make the hospital antibiotic policy, but implementation becomes very difficult. Guidelines for waste segregation, of course there is a statutory requirement in terms of biomedical waste management. So components of a modern infection control and surveillance program should be outbreak prevention, continuous surveillance, then is staff education, training, information, occupational health and safety standards, monitor cleaning, disinfection and sterilization, monitor housekeeping, waste disposal and laundry, advise on hospital construction and purchases, quality management and improvement. So, actually, here I think I will stop in terms of showing you the presentation, but we can discuss aspects about hospital acquired infection which you feel are very, very important in the hospitals. Nowadays, in the accreditation standards for the hospitals also, there is a coverage, entire chapter is covered on hospital acquired infection control. There is a need to define first of all the hospital acquired infections, which are 4 important infections which need to be defined in a hospital setting. One is urinary tract infection. This should be a common definition in the hospital, that what does urinary tract infection mean. The CDC and WHO both have defined these criteria very, very specifically, which need to be measured. Then you have ventilator associated pneumonias, then you have bloodstream infection, you have device related infection. These all should be monitored in the hospital. There has to be a trend analysis, there has to be a tracking mechanism. Then there is need of having a proper surveillance in high risk areas, as I mentioned earlier. In these high risk areas, I would emphasize on operation theatre as well as ICU, intensive care units, where you need to have a separate infection control program defined by either OT committee or a centralized hospital acquired infection control committee defines this in terms of these high risk areas. This is very, very important. From employee safety point of view, I have already covered in terms of pre-prophylaxis and post-exposure prophylaxis has to be carried out. I would also ask Dr. Das if you would like to add something to hospital-acquired infection control program.
Yeah. I think quite significantly all of you are oriented to what hospital infection control is. I think one aspect which we are supposed to cover is linen and laundry, and of course maybe we can chip in here and cover that aspect also. Linen is what term Dr. Ara used, is fomite induced infection. Did you hear that? That is what is called a linen induced infection. So fomites are in linen. So there are linen specifications that are available, and there are different kinds of linen. You use OT counts, you use patient count, you use lab coats, you use neckties and so on and so forth. What are the specifications for procuring those kind of linen, and how are they? Now in terms of infection control, there are 2 components. Number one is there is an important stuff which is called sluicing. And that is supposing in the operating room you have a linen which is a cut sheet and which is used by the surgeon, and it is all soaked in blood. Do you mean to say that the same linen will go back to the launderer? No. It has to be sluiced there, right at the point of origin. You know, that is an important component. So therefore, when he was considering the planning aspect, so you need to be very careful when you plan the operating room, where should the waste be getting out. So that linen encompasses that component. There should be a sluicing, and then of course it could be dried and then it could be sent back to the launderer. When it goes to the laundry. Laundry also, if you see, if you ever had a chance to see a mechanized laundry in a typical hospital, it has got a couple of aspects which are no crisscrossing of traffic. You know, when they just dirty linen and clean linen, they should not be crisscrossing each other in terms of the path. First is of course sluicing, then is you know, the washing, the drying, the calendaring, the repair, and then of course the storing and whatever it is. So crisscrossing should be avoided as far as possible, should not be there in terms of linen and laundry services. There are very many types of laundry. Well, there could be contract basis, there could be mechanics inside the hospital, there could be top-up facility, you know, so on and so forth. We didn't have the time to discuss all that linen aspects in it. And the second important component is the mortuary. Mortuary, there are 2 types. Now, in a typical teaching hospital, there is a vast, elaborate mortuary, wherein there is an autopsy, there is a medical legal cases being taken up, and so on and so forth. Not that all hospitals do have that kind of facility, but typically reasonably sized hospital, they would have a mortuary wherein they have a facility for storage of the body. Now, these are mechanized chambers available, so there are either 2 or 4 chambered facilities available, and you can, what you need to be concerned is about the temperature maintenance and how do you, have you kept the connection, because the mains could go off and it will trip off and there is no load shedding, how will it run? So whether are you going to connect it to the generator or you are going to have a UPS, because else it is no good, because the body which is there inside the mortuary will be affected. Now, in certain hospitals, when in age-old practice, it was it was a habit to procure blocks of ice, and put it into the, which is not probably the correct thing. That is body identification. Well, this is what is most important. How do you identify the body from that mortuary? This body has to be handed over to this next of kin. Now, whether the death certificate, I'm so sorry, death certificate is issued at the mortuary or at the bedside. Now, which is the correct practice? So ideally, it should be, the body should be transported into the mortuary, and the death certificate could be given from the mortuary based on certain identification and certain verification. And the mortuary should be located in a clean, wet, lit place. Ideally, we have seen mortuary to be located at the backyard of the hospital, and in a very dirty and place. It is so sad, because a hospital is a place where you have births, you also have deaths. When you rejoice in terms in a scene where there is a birth takes place and there is a lot of sweets being distributed, we don't know how to address death and be responsive towards the aggrieved family and who are equally stakeholders in our business of healthcare. And what is desirable is to be sensitive. How will you express your sensitivity unless you have kept the mortuary in a nice place? Now, what is nice? Nice is not very elaborate. It should be neat, clean, well lit place. Maybe you can have some plants there where people find it fresh to offer prayers there, because that's the last time they are going to see their next of kin, and thereafter probably they are going to take it to the pyre or whatever, according to different religious customs. So this is, I think, very, very, you need to see it very sensitively. Not any textbooks will give you as to how to, well, there are very many modes of organizing a mortuary.
They may give what is the space required, what are the air conditioning requirements are there, but not these types of things will be not.
Yeah, it is very sad, and it is very, very depressing to see this kind of things. You might do a lot of good things clinically, but then when you go to the mortuary, it reflects very badly on both the hospitals as well as the functionaries.
And then the body need to be covered. Like sometimes what happened, few cases have been seen that where they take off the hospital bed sheet also. I think we must respect that thing, and we should not for a few rupees or for something that, as you are saying, that
they create a scene. They pack the body into the hospital bed sheet, and then they charge the patient
for the patient, or they remove it or ask the patient to bring their own bed sheet. I think
it is so distasteful to discuss this also, unless you face it yourself, which I hope and pray not to happen. But that is how it is. It's a good habit and good practice to practice those poly bags. Polybags are available, and they come for a cost. And they cost you around 100, 150 rupees, and that is the least you can do to a patient who has been cared by you. Well, these are important things, and which we commonly ignore. And they are usually shady, very, very dirty, very smelling. No one cleans the mortuary. No one ever gets into that. It is hardly air conditioned. It is not connected. Even if it is a double chambered or 4 chambered, it is not often connected to the generator or the. Forget about UPS. Well, UPS are expensive. UPS is given connection only to the operating room and probably the blood bank, not to the mortuary. But at least a generator connection should be there, wherein it should be, and someone should come and check whether the meter is working all right, the temperature recording is being done all right or not.
So, Dr. Das, I would like to also add 1 or 2 points to what we discussed on laundry as well as on the mortuary. One small thing which I wanted to add was that normally we have, we are not very much concerned in terms of.
There is a phone call from her.
Okay.
Yes, please.
Hello.
Yes, please.
Hello.
Yes, please.
Sir, I am from the Bhubaneswar Center. I am a student of PGD HHM.
You are Dr. Prashant?
My name is Prashant, sir.
Yeah, we have got your
sir,
facts.
I want to know whether I can get the CD of this course materials.
If you're watching, why you want a CD? Tell me first.
Hello.
Huh?
Hello, sir.
If you're watching this thing, why you want a CD?
Hello.
Yes, please.
Sir, I am Prashant.
I have got your facts
from-
also. And why you want a CD?
Sir, actually, I want to ask to whether I can get the CD of the course materials.
Okay, I tell you a better method. What you do that you go onto our website www.ignu.ac.in.
Sir, this episode course materials, sir.
Huh?
This
First,
episode, sir, whatever, yeah.
I'm telling you that you will get so many CDs of this particular program, DHHM program. What you do that you go on our website www.ignu.ac.in. On that you go to E-Gyan Kosh. E-Gyan Kosh.
Okay, sir.
E-Gyan Kosh, you just press it. There will be a icon there which says YouTube. Y-O-U Tube. YouTube. You press that YouTube.
Sir,
Yes.
sir, that is the previous matter, but I want to know this teleconferencing section.
This teleconferencing, that of course you are right that will be old one. You can, but anyway, for the information of other students, you can go to the YouTube and you can see. Maybe this will be last year's, but this mortuary services, hospital acquired infection, this may be there. You open the YouTube and then you can see that this teleconferencing session over there, recorded one. Okay. Anyway, I have got your this phone fax number. I will try to communicate with you and try to send these today's CDs definitely.
I was discussing that some important issues other than what Dr. Das has also mentioned regarding we have a habit of just throwing the linen after the patient is gone or discharged, and we keep it in one corner near the nursing station and then send it later by some laundry worker. It is best practice to actually bag it at the source. It should not be thrown like this near the nursing station or kept in a corner. It is better to seal that in the ward itself and then send it to laundry. Even if it is not soiled, even if it is a normal discharge of the patient, still it needs to be bagged at the source, and then that is a good practice. Again, other practices he has already said about the sluicing or doing the sluicing at the source, that is in the operation theatre or in the ICU, in a dirty utility area where these things can be done. And in the case of mortuary also, one infection control in mortuary is becoming very, very important area, and that should be part of your infection control manual, in fact, that how to control infection in the mortuary practices. Many places, the medical colleges especially, where we are doing post-mortem examinations, there again HIV bodies are there, and various other aspects of infection control also have to be taken care of while doing this autopsy, as well as a routine hygiene sanitation, what Dr. Das also said, has to be maintained of mortuary to contain the infections. And transmission to the staff is a very big factor which is there in the mortuary. So that should be taken care of.
Shall we quickly discuss something on disaster?
Disaster.
I think we have got 13 to 14 minutes, and maybe
we can
some
quickly either if you have questions or you can give a summary as to what disasters are. I think I can initiate and Dr. Rao can probably take it up later.
Yes.
Disasters that we all have, we all know there are two kinds of disaster mostly. One is a man-made and of course second is a natural disaster. There is a third one which Dr. Rao is very expert in that is for nuclear biological welfare, because he comes from the army background, so he will be very eloquent in that aspect. This is also an important, and please understand why I had to use this term, because there is something which is called a national disaster plan, which is controlled by the Prime Minister's office, and this has a strong impetus, nuclear biological warfare. And this is a hierarchy: national disaster management plan, and there is a state disaster management plan, then there is a district disaster management plan, and that is the hub. From the district, every hospital is linked. All right. Now, what is a hospital disaster management plan? We will come to the hospital disaster management plan. Unless, if you have understood this tree, and this is the hierarchy, and disaster is something that you cannot ignore. It is something that you have to take it with utmost seriousness, because probably you have not had the opportunity to probably see, visualize, or be participating in a disaster-like situation. So I think we'll go to the hospital disaster management plan, the last. Okay. Now there is something which I need to address. Is one is a mass casualty and second is a disaster. What is a disaster by definition? We have been using this term. An overwhelming phenomenon which has to be repeated, which will be repeated in any case.
Yeah.
It is an overwhelming phenomena. It will be repeated, but there are very many definitions. It's a very small and crisp definition to that we need to address here. It's an overwhelming phenomena which would need external assistance. You cannot do it by your own self, which will need external assistance. You cannot do it because it is so incapacitating and oh so overbearing that you cannot handle. Therefore, the second corollary is a mass casualty. Now, there is a difference between what is a mass casualty and what is a disaster. A mass casualty, in contrast to the disaster, is probably what you can probably handle yourself. And suppose, I'll give you an example, you are a hospital having an emergency room and you are a 200-bedded facility having an emergency attendance of roughly 30 patients in a day, or 40 patients in a day. At any point of time there will be 5 or 10 patients. Now, supposing you get 30 patients at one time, I'm sure you can pull up your socks and you can handle it. But in case you get 300 patients, I'm sure that you cannot handle. Now, this is the difference. What is a mass casualty and what is a disaster? A mass casualty is something that you can handle within your own resources. Within your own resources. A disaster is something that you would need an external assistance. Clear? Now, quickly, then we have to take something new, which is called a triaging. So, triaging is a segregation of patients according to their seriousness. And Dr. Rao has some slides, we'll show you that as if time permits. Triaging is a process of segregation of patients according to their seriousness. So there are different kinds of triage bands available, and which is an international phenomena. It is not a something that you and me can choose. There are a red, orange, green, and of course is there, right, black. So these are according to prioritization, and triaging is usually worldwide. It's a nursing activity because there is something which is called a command nucleus. These are the terms that we are using is according to the National Disaster Management Plan. Command nucleus is almost like a control room. The medical superintendent, the medical director, or the chief of the hospital will take over, whoever it is, whoever he or she is something that we call as a command nucleus. This command nucleus is manned by the leader. And in the disaster-like situation, it is a autocratic leadership or situational leadership. I command and you follow. No argument, no questions. It's a command and everyone has to follow. So, well, that is, we'll discuss, Dr. Rao will discuss that. I'll just give you the introduction. So, okay.
The various criteria of triage, which are called triage sort or triage sieve. In that, the triage criteria, like Dr. Das pointed out, red is the first priority, most immediate, where there is a danger of life-threatening shock or life and limb surgery has to be carried out. So that becomes a first priority. Second priority is your yellow, or injuries which will have systemic implications or effects, but patients are not yet in shock or hypoxia. They will be able to give you around 45 minutes of time where you can do actually intervention. So criteria as per start not falling in priority 1 or 2 will be in the yellow category. Then we have a green priority, a green category, which is third priority. We also call in armed forces this as a walking wounded type of casualty, which can actually go to the command post, what Dr. Das was mentioning. There they can take the treatment. You don't have to really extract them from the site. They can come themselves and give you adequate time to attend to their casualties, attend to their problems. So that those casualties are called green casualties, and black of course is rarely used, but it is for the dead, or also we call expectant category. Expectant category is where the death is imminent, means you cannot actually salvage that patient. So that can be also categorized under the black, and priority can be accordingly allotted. Why do we need triage? Triage is needed, as Dr. Das also brought, brought out, mass casualty phenomena, you have a limited and inadequate resources to handle such type of casualties. So you actually need to focus on where it will benefit the maximum. So that is the principle behind it, that you have to benefit the maximum people who really need care. Like we showed you, red category, which is the most immediate, first priority should be given to that, and it should be tackled. That means your surgical team which is there, which is able to handle around 12 cases a day or maybe 20 cases a day, then they should give priority to these casualties first. And then of course the yellow category, which can be taken care of maybe by the physicians also, and then so on and so forth. So actually, as we were discussing, all this has been now made into a policy at the national level, which is called NDMA, what Dr. Das also said. And from the audience also this question was asked regarding what is the current preparation of this country as far as national disasters are concerned. So we have a National Disaster Management Authority. This is by the Act of Parliament, actually this has been created in September 2005. It is also called DM Act, which has been promulgated, and then followed by which the NDMA was created. Earlier only nodal ministry was Ministry of Home Affairs. Now there are so many ministries who are taking part in this NDMA, and we have 8 NDRRF, which are called National Disaster Response Force, which can, but these are battalions of people who can actually rush to various sites. Of course, Army continues to be the first responder in case of disasters, whether that was floods which you just now faced a few days back, or earthquake which we faced in JNK in 2005, or in Bhoj 2001. Everywhere the first responder responsibility is generally given to armed forces, who have a organized force who can reach that particular site within no time and do with the various measures. But on the similar lines, this NDRRF concept has come, where National Disaster Response Force has been created. Also we have something called standardized brick system, by which the medical stores are prepared in a brick manner. Whatever is the requirement of the medical stores, I will try to focus only on the medical aspects. I am not going into the details of various other disaster related aspects, like engineers are required, or rescue equipment is required, police is required, fire protection is required. All that we are not discussing here. We are focusing mainly on the medical aspect. For that we have a standardized brick systems. These standardized bricks have been located at 14 places all across India. Along with that, Army, these have been based on armed forces stores already existing, based on the same locations, and National Disaster Management Authority has also done the same task. And plus Dr. Das was specifically pointing to me about the CBRN phenomena, what is chemical, biological, radiological and nuclear response. CBRN response, what we call. For that we have created at 6 places in this country, at 6 different places. These battalions are equipped with this NBC equipment, as well as they have all the CBRN measures in place. Various centers wherever nuclear medicine is there functioning, there these protective mechanism will also come into force, because those are also dangerously can be used by the terrorists for the purpose of radiological safety. These things have to be taken care of. So as I said, that at a national level the preparation is like this: first responder, armed forces, or partially we can say second responder, or even first responder is National Disaster Management Force, followed by the state government authorities. They take over slowly and they enter into the post-disaster phase. But of course the state government's coordination with the at the national level is of paramount importance. Then various other events like what Dr. Das was mentioning about hospital disaster plan, evacuation. Sadly, the transportation mechanism and communication mechanism in the disasters still remains a very big bugbear, because we do not have something called ambulance services at a national level, which is there in other countries, developed countries like NHS has its own ambulance service. In America, of course, they have own ambulance service. In our country also, certain pilot projects have been undertaken like CATS, like EMRI in the Andhra Pradesh. So these are pilot projects, but this is being formed up at the national level, where we are going to have a Indian ambulance network, or IAN what they call, and this is going to be at a national level. And this has been proposed by Health Minister recently again, and reiterated that EMRI is also being incorporated into this aspect. I think if there are any further questions,
I think
that will be better.
concluding is you must know how to make a hospital disaster management plan.
Yeah.
It's very crisp, 4 to 5 pager, clear areas of responsibilities and tasks. Who will give the alarm? Who will qualify the call? Qualification is a confirmation that yes, there is an air crash and victims are being transported to our hospital. Confirmation, qualification, and then of course the whole jing bang starts. It is the command nucleus. The command nucleus, the term is peculiarly used by NDMA, and you have to by default use this term. You cannot call it a control room. You cannot call command nucleus, triage room, specific job response, storekeeper, blood bank, response times, and you must know how to maintain a report of the disaster drill that you carry out. So these are a couple of things.
And also time to time they should carry out the drills also.
Yeah, that's right.
So I think we have to end here. The time is over, and I must thank Colonel Rao, Dr. Das, for being here on the Sunday day and being with us and giving very useful inputs to our students. I think students must have been definitely benefited by your inputs. Thanks once again. And I also thank all the students who have come here, and the students who have been watching this teleconferencing, sitting at the various regional centers. Next time we'll be covering that the remaining areas of course 5, and again I will time and again I've been requesting you that it is always better you just put across some questions. If not during the teleconferencing, if you are hesitant or you are not able to connect to us, maybe earlier also, like tomorrow you can send some questions through email to me. You can fax some question to me, so which I can take up in the next teleconferencing session, because basic purpose of this teleconferencing session is to have interaction. It's not the lecture type of thing, because the lectures you are already having at your program study center. So with these words, once again thanking you, all of you.